Hi, I'm Dr. Mladenoff. I'm happy to be with you in this presentation today for the 2021 ICAK Annual Convention. I like to start every presentation with an intention. What is your intention to be here? What is my intention of what I want to share with you about the vestibular nuclei evaluation and treatment? And that simply is based on a quote by Miyamoto Musashi, and that is, perceive that which cannot be seen with the eye. And that encompasses, for me, what applied kinesiology allows us to do. It allows us to evaluate the body and look for things that we cannot see for the eye or with the eye. And we, as Dr. Goodhart said, we need to see with eyes that see, hear with ears that hear, and feel with hands that feel. One of the things that we've developed over time is what I call our concussionology matrix, and that is in any head trauma, in any concussion, there are 5 major injuries that occur. There's a cervical spine injury, there's a pituitary stalk injury, there's neuroinflammatory cascade, there's a metabolic cascade that is different from neuroinflammation, and there is vestibular injury. So these 5 areas are very important, and we're going to be discussing the vestibular area in very specific detail today. Let's do a quick workshop on the vestibular nuclei and the vestibular spinal tract. So what I want you to do is you're going to check on your partner. First, check neck flexor muscles as a group, and then neck extensor muscles as a group. Check for autogenic inhibition on both of those. Then what I want you to do is check a rectus femoris. We can do this in a sitting position, a rectus femoris, and then a hamstring muscle. Check for autogenic inhibition on both of those. So now the first test you're going to do is you're going to have the patient, we'll eventually do these in all 3 directions. Let's just do it in rotation first. So what I want the subject to do is turn your head from side to side, but move your eyes with your head. So you're going to go side to side, eyes moving with your head 4 or 5 times, come back to neutral, and then examiner, retest neck flexors, neck extensors, check for autogenic inhibition, write down your findings, and then also check trunk flexors, extensors, write down your findings. Then the next test I want you to do is we're going to repeat the test, but now the patient is going to keep their eyes focused ahead, turn the head side to side, rotate side to side, but keep eyes looking straight ahead. Come back to neutral, then test neck flexors, neck extensors, check for autogenic inhibition. Was there any normal inhibition? Check trunk flexors, trunk extensors. Was there any facilitation, any inhibition? Write down your findings.
Let's change partners now. The first step is, remember, we have medial vestibular nuclei, lateral vestibular nuclei. So, patient sitting, doctor check head and neck flexors as a group. Check for autogenic inhibition, check neck extensors, and test for normal autogenic inhibition. For the lateral vestibular nuclei, we're going to check extensor flexor muscles of the trunk. So we're going to pre-test by testing the rectus femoris, checking for normal autogenic inhibition, and checking the hamstring, and then testing for normal autogenic inhibition. Our next step now is to turn the head and neck from side to side, but have the eyes move with the head. So turning head side to side, eyes move with the head, then retest the neck flexors and extensors. Make sure you evaluate for autogenic inhibition in both cases, and then test the trunk flexors and extensors, rectus femoris and hamstrings, and then also determine is autogenic inhibition normally functioning. Stay with me now. The next step is we're now going to repeat turning the head side to side, but have the subject focus their eyes on an object straight ahead. So if I'm standing in front of the patient, I will just say, okay, focus your eyes on something at eye level, my chin or a button on my shirt or my nose or something. So patient is going to look straight ahead, turn head side to side while keeping eyes focused forward. Do that 3 or 4 times, and then have the retesting of neck flexors and extensors. Again, evaluate for normal function of autogenic inhibition. Then test rectus femoris and hamstrings, testing for normal function with normal autogenic inhibition as well. Write down your findings. The slides and handouts you received as part of your registration package are not in a print quality capability, and they would be printed over several pages. So if you would like some of the workshops that we're talking about, some of the forms that we're going to talk about a little later on, if you just take out your cell phone and send a text message to 844-539-1326 and type in the message, the word ICAK21, it will have a short pause or delay rather. It'll ask you for your first name, last name, and your email, and then it will send you an automated response, and then in about 10 minutes you'll start getting the forms for the questionnaires. You'll start getting the pages to print out so that you can have amalgamated stuff printed on 1 or 2 pages instead of 10 or 15 slides. So again, text the word ICAK21 to 844-539-1326.
One of the things that I like to describe for patients is what happens in a concussion is, here in Kansas, we are in Tornado Alley. And so what happens is we will have storms come, and when there is a perfect storm, we will get damage to property. So a perfect storm will, in an athletic event, and with head trauma, and then we get the negative effects. So this pictograph that I've got on there describing what happens in a tornado is a dramatic representation of what happens when you get head trauma. So again, 5 injuries occur: cervical spine injury, pituitary stalk, neuroinflammation, metabolic cascade, and a vestibular injury. So we are going to just talk about the vestibular injury area, and there are 5 areas in the vestibular matrix. So there's the vestibular nuclei, the cerebellum, the brainstem, the cerebral cortex, and the nuclei thalamus. So we are going to just talk about the vestibular nuclei in this presentation.
The vestibular system is an integral GPS system for the body. This is an analogy I like to use for patients. So it's like your car, where the vestibular system is housed. You begin at home. Then you have the roads. So the vestibular or GPS system sends messages and signals of which the roads the body must follow. Then you have a destination where your vestibular system directs you to go. And then you have the base or the ground. So gravity, the vestibular system tells the body where it is in relations to time and space. So we have visual information that tells the eyes what they are seeing in correlation with objects, words, and so on. We have auditory input that tells your ears what to receive, store, and recall. Then we have motor planning that tells the body how to respond to motor skills. And of course this then tells muscles, joints, and tendons what to do, where to move in 3-dimensional space. Then we have tactile feedback that recognizes texture, sensory information in the environment. Then we have hand-eye coordination that tells the body how to coordinate the eyes with the hands for tracking, reading, writing. And then we have proprioception, or how we sense objects and interpret messages. And so we have behavioral attention and fidgeting that helps a child's actions become automatic, so they don't have to think about sitting in their chair, listening to what the teacher says, or regulating emotions. Traumatic brain injuries, regardless of severity, are one of the leading causes of vestibular complications, and they also can negatively impact a patient's tolerance for light as well. Not only are dizziness and light sensitivity regular symptoms within the first few days after a concussion, at as little as 40% or more, but their presence during this time may predict the likelihood of long-term symptoms of a year or longer. Sadly, they can also become a chronic problem for many, persisting for years after the initial head trauma. Recently, research began to explore how light sensitivity and other visual inputs can lead to the vestibular effects associated with brain injuries. One study found that more than half of teenage athletes who endured a sports concussion cited computer use and television watching as triggers of their dizziness. While motion sensitivity may also be a compounding factor, it is likely that the artificial light exposure also contributed to these experiences. And this is reinforced by repeated findings that people with a concussion have a lower threshold for bright light. Much like migraine, this makes patients susceptible to having their post-concussion and post-TBI induced by light, even at levels that others may not consider bright at all. This pictogram from the ottoolbox.com is a simplistic form of the vestibular system that we like to hand out to patients. So it begins with the receptors in the inner ear that then go to the brainstem. And then from the brainstem there are connections to the cerebellum, the spinal cord, the oculomotor nuclei, and the thalamus and cortex. So the cerebellum coordinates eye control, head movement and posture. The spinal cord influences muscle tone and postural adjustment. The oculomotor nuclei steadies the eyes as the head and body move. And then the thalamus and cortex interprets input and plays a role in the motion perception and spatial orientation. The vestibular system is affected in nearly 60% of youth and adolescent athletes following a concussion. So we should think of the vestibular system like a gyroscope. So the inner ears and your vestibular system detects motion or your position of the head in space, and it sends information to the brain that's needed for balance and stable positioning. Some of the telltale signs of a vestibular injury are difficulty with balance, dizziness, it may feel like the room is spinning, or a slow, wavy sensation like you're on a boat. There may be trouble stabilizing vision when moving your head. This is called the vestibulo-ocular reflex. And now, if you're riding in a car with a vestibular concussion, you can't stay focused. So the technical name for this is the visual motion sensitivity, or VMS. There may be three things that could trigger symptoms in these patients: dynamic movements, busy environments like a grocery store, like church in a crowd, or just an athletic event. Vestibular therapy is much needed in these patients. A closer look at the function of the vestibular system reveals two distinct organs, the otolith organs and the semicircular canals. They each perform two distinct functions in detecting motion of the head. So on the viewing left, you see that a static head position, and we have linear acceleration of the head. This is detected by the otolith organs. Versus rotational acceleration, this is done by the semicircular canal. So we can have rotation around the z-axis, or a yaw motion. We can have rotation around the x-axis, or the roll, or we can have rotation around the y-axis, which is pitch. So this is the classic pitch, roll, and yaw that happens in an airplane, for example. Looking closer at this vestibular labyrinth, we see several things in this particular diagram. First of all, we have input from the vestibular portion of cranial nerve 8. Then we have embryologically the vestibular labyrinth arising from the otic placoid together with the cochlea, and this represents a set of interconnected channels. Then anatomically we have two classes of sensory structures. First, the otolith organs. So we have the utricle first, and then the sacculus second, or the saccule. And remember, these two organs detect head acceleration and trigger a response in the body to balance head on neck. Then we have the semicircular canals, and again, the semicircular canals detect rotational movements. So the canals are filled with endolymph, which is high in potassium, low in sodium, and they are surrounded by perilymph, which is low in sodium and high in potassium. So if the patient has a cellular disturbance in sodium and potassium levels, this could affect the function of the semicircular canals. Now the semicircular canals functions as pairs. So we have the left horizontal and right horizontal semicircular canal. They work together. So that's rotating head side to side. Then we have the left anterior or superior semicircular canal and the right posterior semicircular canal work together. and then the left posterior and right anterior semicircular canal work together. And again, remember, these semicircular canals will be triggered and fired when there is changes in rotational forces in the X, Y, and Z axis, or the classical pitch, roll, and yaw pattern that we see when airplanes move. This is also used to describe the position of head in three-dimensional space where it moves. The central vestibular processing occurs at 3 levels. So you have the ganglion cells being fired, and then this will then trigger the vestibular nuclei, the superior, medial, and lateral vestibular nuclei in the rostral medulla and the caudal pons. Then we have the vestibulocerebellum being triggered at the flocculonodular lobe in the cerebellum. And third, the reticular formation is triggered in the brainstem. We're going to discuss these in a little more detail shortly. Specifically in regulating posture, the vestibular system has a number of different areas. So on this particular diagram, if we look at the cerebellum in purple on the upper right hand side, there will be information going from the cerebellum to the LVN, is the lateral vestibulospinal tract and the lateral vestibular nucleus, and it goes to the muscles of the lower limb, basically the trunk flexors and trunk extensors. Then we have the cerebellum going to the medial vestibular nuclei, and it then goes to spinal motor neurons and goes to the muscles of the head and neck. And then finally we have the vestibulocervical reflex. This is a bilateral reflex that goes to and from the medial vestibulospinal tract and also to the muscles of the upper neck and upper limbs. So the medial and lateral vestibular nuclei control not just head and neck posture, but trunk posture as well. And again, we will be discussing these in more detail, and this is where our AK capability to evaluate nervous system function will become very clear of how we can delineate which one of the vestibular nuclei is dysfunctioning. Multiple things have to happen to control balance, starting with sensory input, then the input is integrated, then we have motor output, and then we'll get ultimately balance. So let's look at these individual factors. On sensory input, we're going to have input from the vestibular system, equilibrium, spatial awareness, rotation, and linear movement. There will be visual, insight, information coming in, and then there'll be proprioceptive touch coming in. All of this sensory input is then integrated in a number of areas. The cerebellum coordinates and regulates posture, movement, and balance, and the cerebral cortex contributes higher level thinking and memory. All that information is then directed to the brainstem, where integration and sorting of sensory information occurs. All of these then are directed towards motor output, beginning with the vestibulo-ocular reflex, motor impulses to control eye movements, and then motor impulses to make postural adjustments, and ultimately then control balance. Again, recall this is all coming from that sensory input, changes of where our body is in three-dimensional space, and then how our body reacts to all those different parameters.
The classic vestibular examination does not allow for evaluation of the medial and lateral vestibular nuclei. So we can do subjective vestibular evaluations. Whenever you look at the literature, they're all going to use some or combinations of these paper questions, the visual analog scale. There's a visual vertigo analog scale, the activity-specific balance confidence scale, a dizziness handicap inventory scale. I have copies of all these. I'd be happy to send them to you. We'll show you how at the end of the presentation that you can contact me so I can send you all these questionnaires that you can use. But for me, here's the bottom line is these questionnaires don't tell us the function of the vestibular nuclei. They don't tell us the function of central nervous system. They don't tell us neurological response in the muscle system of head and neck balance. And it doesn't get the patient better. It doesn't tell us what to fix. There can be special neurological exams, and again, these are things that we will do in classic neurology or in functional neurology. So we can have the vestibulo-ocular reflex, the vestibulokinetic reflex, the vestibulocerebellar reflex, the vestibulospinal reflex, a classic Romberg's test, a balance error scoring system, and then gait and dual tasking examination.
Diagnostic tests for concussion can be very complex. This was an article published in the Journal of Neuro-Ophthalmology of the North American Neuro-Ophthalmology Society in 2015. They did a literature search, PubMed search of all articles dealing with concussion, mild traumatic brain injury, neuro-ophthalmological findings, and diagnostic and management tests. And what they concluded was, first of all, concussion is associated with many neuro-ophthalmologic signs and symptoms, and visual performance measures enhance the detection and management of concussion, and future studies, of course, are underway. They concluded that the ability to diagnose convergence, saccades, pursuit eye movements, accommodation, and the vestibular ocular reflex all gave early clues about long-term recovery time period of patients who had concussions. They also concluded that this should be an added metric to sideline examination to injured athletes, and of course follow up with many diagnostic capabilities, computerized testing, imaging modalities, and electrophysiological testing of neuro-ophthalmological function evaluation. American Journal of Sports Medicine in 2018 found that vestibular ocular motor exam should be the baseline exam because it has a low false positive. The American Journal of Sports Medicine in 2017 found that the vestibular and ocular motor screening was a predictor of recovery time. So if these tests were positive in your initial exam, it would indicate a slower recovery time. If these tests were negative at your initial intake, that means the patient would recover faster. The Journal of Pediatrics in 2015, they found that prolonged recovery time, there was vestibular deficits associated with extended recovery times and poor neurocognitive testing. 247 patients from 3,740 eligible visits for detailed review and abstraction. 81% showed a vestibular abnormality on initial clinical exam. The patients with vestibular signs on the initial exam took a significantly longer time to return to school or to be fully cleared. The average time for return to school was 59 days, plus or minus 6 days, and to be fully cleared to return to play was an average of 106 days versus the 29 days of return to learn. That is dramatically different than the information from the CDC that shows 23 days for children and believe it was 18 or 19 days for adults, 106 days for a return to play, and 59 days for a return to learn. Journal of Pediatrics in 2015 found that vestibular deficits were high, prevalent, caused an extended recovery time, and there was a poor performance on neurocognitive testing. So, several things here. You have to evaluate vestibular system, and you have to evaluate neurocognitive testing, not just symptoms. International Journal of Sports Medicine in 2018 found that the vestibular and ocular motor testing proved 90% accurate. And here's some of the tests that they found important: a gaze stabilization test, a rapid eye horizontal test, the opticokinetic stimulation, smooth pursuits slow, smooth pursuits fast tests, near point conversion. Distance were significantly greater at initial assessment in both injury groups compared to normal. So vestibular and ocular testing is going to be important in our examination procedure to help us determine the return to learn and return to play criteria. We're going to be discussing some of these tests in more detail in Masterclass number 2.
The vestibulo-ocular reflex generates eye movements that enable clear vision while the head is in motion. So if you just took a piece of paper and held it up at arm's length away from you, so Dr. Chip, let's pretend you're doing that, okay, and you turn your head side to side, Okay, the eyes will stay focused on that, so you should be able to read clearly when we do this. Okay, now if you hold your head still, then move your hand side to side with that piece of paper. Okay, it'll probably be blurry because the vestibulokinetic reflex is working properly. So the way we're going to evaluate the vestibulo-ocular reflex, or the VOR for short, now I'm going to be standing to the side. Normally I would be directly in front of the patient. I've seen this done many ways. So I would do it gently first. So we're going to have him focus on an object right here. So if I'm standing in front of the patient, I'm going to say, okay, focus on your eyes on my chin or whatever is about eye level with the patient. We're going to have, the doctor will gently rotate side to side. You can see Dr. Chip's eyes staying focused on the camera. So I'm going to do it passively and make sure the eyes track. I've also seen this done, and I would caution you to do this if you're doing this on the sideline, to do a violent motion like that. Do it 3 or 4 times to one side, 3 or 4 times to the other side, and then also in the vertical, I would do it passively first, and then again you can do it a little quicker, a little more violently, see that the eyes stay focused. So again, be cautious with this one, do it passively first, then you can do it a little more aggressively second. The vestibulokinetic reflex, or the optokinetic reflex, allows the eyes to follow an object in motion when the head is stationary. So we like to use this Optodrum app that you have. Some of you use the old bar piece of paper or a scarf that I've seen from way long time ago. So the Optodrum allows you to control the speed and the color of the stripes that go by, and simply you're going to hold your phone about 12 inches away, and you're going to check for saccades and pursuits. So what will happen in this test is, if the patient's eyes do not move and can't follow the stripes, it's totally involuntary, then you know, okay, there's an optokinetic reflex problem.
The app I like to use for the examination that we just conducted is called OK and Strips. If you go to your app store or whatever your device is, when I purchased it, it was only $3.99, and it is a very useful app that you saw we did in the demonstration. Again, go to your app store on whatever your mobile device is and download the OK and Strips app, $3.99. It will make this testing go very, very easy. The Vestibular Disorders Association recommends the following vestibular diagnostic tests be performed on a patient who has sustained a concussion: an ENG or VNG, rotation test, the VHIT test, the VEMP test, dynamic gait posturography, audiometry, autoacoustic emissions, electrocochleography, auditory brainstem response test, an MRI, and or a CT scan. Most of these involve a lot of technology, but again, they do not help us evaluate vestibular nuclei function and neuromuscular control of head and neck balance and trunk balance. There are many possible causes of vestibular nuclei dysfunction that we need to diagnostically consider, especially when you're dealing with non-concussed patients or have no history of any head trauma or car accident, whiplash kind of injuries. In a general sense, we need to consider carotid disease, vertebral artery disease, cardiac arrhythmia, and orthostatic hypotension. There can be peripheral causes of vestibular nuclei dysfunction, including cervicogenic dizziness, benign paroxysmal positional vertigo, Meniere's disease, vestibular neuronitis or vestibular labyrinthitis, superior canal dehiscensis, vestibular migraine, and acoustic neuroma. There can be central causes of vestibular nuclei dysfunction, and these include multiple sclerosis, atypical Parkinson's disease, stroke, migraine, cerebellar disorders, yes, concussion, which we have discussed in detail and will continue to discuss, but we also need to consider what medications the patient is on, is there any psychogenic problems, and is there any cardiovascular autonomic dysfunction. You need to print this diagram out and study this diagram in detail to understand the complex neurology that I'm going to attempt to make very simple over the next few slides. So the vestibular nucleus input comes from multiple areas, but let's look at several different things. First, this is the medial vestibular nucleus. This is the superior vestibular nucleus. This is the inferior vestibular nucleus. And this is the lateral vestibular nucleus. So keep those in mind when we go to the left-hand side of this diagram. So the semicircular canals, remember they detect rotational changes of head position. They send their information to the superior vestibular nucleus and the medial vestibular nucleus. The utricle sends its information, remember this is linear acceleration, sends its information to the lateral vestibular nucleus. And then the saccule sends its information, again linear acceleration, sends its information to the lateral vestibular nucleus and to the inferior vestibular nucleus. We're going to come back to the output in just a moment. On the following slides, we're going to show you several videos that were taken from the University of Texas McGovern School of Medicine Neuroscience online program. And this is from Chapter 11, the vestibular system, pathways, and reflexes. This particular figure shows a summary of the ascending and descending vestibular pathways. When you watch the video play, the 4 vestibular nuclei appear in the outline. Note that the nuclei have medial and inferior nuclei seen together in the rostral medulla. The lateral and superior nuclei are smaller and are seen in the pons. The ascending tracts are shown in blue. These arise from the superior and medial nuclei and ascend into the medial longitudinal fasciculus, MLF for abbreviation, and you can see it right here, to the oculomotor nuclei of cranial nerves 3, 4, and 6. The lateral vestibular tract is shown in green. It descends ipsilaterally to the sacral cord. The medial vestibulospinal tract is shown in red. It descends bilaterally to the medial longitudinal fasciculus to the thoracic levels. The cerebellar afferents are not shown in this summary, but these come from the medial and inferior cerebellar afferents, and they are not shown in this summary, but they come from the medial and inferior vestibular nuclei. The first order vestibular afferents arise in Scarpa's ganglion, which is in the distal portion of the internal auditory meatus. The axons travel in the vestibular portion of the 8th cranial nerve and enter the brainstem at the pontomedullary junction. This animation shows the vestibular connections to the oculomotor nuclei. The vestibular fibers ascending in the medial longitudinal fasciculus to the oculomotor nuclei. Second order afferents arise in the medial and superior vestibular nuclei. Connections from the medial longitudinal fasciculus to the abducens, trochlear, and oculomotor nuclei can be seen. These connections coordinate eye movements in response to head movements. Details of this coordination for horizontal eye movements are elaborated in this section on the vestibular structure and function. This animation shows controversial details of the ascending vestibular pathway that gives rise to the conscious perception. Afferents from primarily the superior vestibular nucleus ascend to the thalamus, probably in the lateral lemniscus or in the reticular formation beside the medial longitudinal fasciculus. The primary cortical receiving areas for the vestibular system are more diffuse than for other sensory systems, and there is some dispute about their locations. Most people believe there is a cortical vestibular area in the parietal lobe near where the intraparietal sulcus meets the post-central gyrus. This would be close to the somatic area of the head, which makes sense for the sensation of dizziness. Others believe there is an area of vestibular cortex anterior to the primary auditory cortex. This pathway is bilateral. This animation shows details of the vestibulocerebellar connections. Some vestibular afferents go directly to the cerebellum through the inferior cerebellar peduncle. Most first-order afferents synapse in the medial and inferior vestibular nuclei and then ascend to the cerebellum in the inferior cerebellar peduncle. Most of these afferents innervate the flocculonodular node. Many interconnections are found between the vestibular nuclei and the cerebellum, which coordinate postural movements. This animation shows details of the lateral vestibulospinal tract. As the name suggests, the tract arises in the lateral vestibular nucleus. The tract descends through the inferior vestibular nucleus, giving this nucleus its salt and pepper appearance. Below the medulla, the lateral vestibulospinal tract descends in the anterior white matter down the entire length of the spinal cord. This tract modulates postural adjustments to movements. So, for example, the reason we stagger after spinning is due to excess activity in the lateral vestibulospinal tract. Now, I'd like to focus on the vestibular nucleus output. We've discussed the input from the otoliths, we've discussed the input from the semicircular canals. So now let's focus on the output, which is where our applied kinesiology examination protocols are going to help us. So first of all, the red line indicates where the location of the vestibular nuclear system is. So the first area is we have output going down the vestibulospinal tract. Then we have the vestibulocerebellar tract, which goes backwards. Then we have output that goes up via the vestibulocerebral tract. And then we have what I call up, meaning the output goes all the way up to the thalamus. So in this picture animation that we're going to see, these are the vestibular nuclei. S is for superior, I is for inferior, L is for lateral, M is for medial. So the medial has output motor pathways for the head and neck movement. And what happens when we get stimulation of the semicircular canals, and this is where we're going with our examination protocols, we get facilitation of head and neck extensors and inhibition of head and neck flexors. The lateral vestibular nucleus goes to trunk and limb extensor movement, mainly the anti-gravity muscles, to maintain erect posture. So what we will have is trunk and lower limb extensor facilitation and trunk and lower limb flexor inhibition. The backwards movement that we have for the vestibular nuclei, three of them, the superior, lateral, and inferior, send messages via the vestibulocerebellar tract. These are responsible for posture, muscle tone, and unconscious balance. The vestibular nuclear output that goes up goes via the vestibulocerebral tract. And so we have output from the medial vestibular nuclei that crosses the midline that will innervate cranial nerve 6 and the eye muscles. Then we have it crossing past the midline back to the original side to cranial nerve 3, affecting the medial rectus, and then cranial nerve 4, the superior oblique. So what happens here, let's give you an example. The left vestibular nucleus, medial vestibular nucleus, crosses the midline and innervates cranial nerve 6 on the right. It then crosses back to the left side and innervates cranial nerve 3 and cranial nerve 4 on the left side. So the left medial vestibular nucleus innervates right cranial nerve 6 and left cranial nerve 3 and 4. The last phase of vestibular nuclei output is the up-up, and this goes via the thalamus. So the superior vestibular nucleus sends its afferent to the thalamus via the ventroposteromedial nucleus. It then goes to the corona radiata, and then has 3 different connections: the lateral postcentral gyrus, the insular cortex, and the temporoparietal cortex. And then this is how we become aware of our vestibular sensations. So here are the 4 pathways. The blue on the bottom is the output, vestibular nuclei output, that goes down. So we have the medial vestibular nucleus going to the motor pathways of the head and neck movement. So it facilitates the semicircular canal activation, causes facilitation of neck extensors, inhibition of neck flexors. The lateral vestibular nucleus goes down to the trunk and limb extensors, or the anti-gravity muscles, so activation of the semicircular canals will cause facilitation of trunk and limb extensors and inhibition of trunk and limb flexors. The backwards motion from the superior, lateral, and inferior vestibular nuclei go to the vestibulocerebellum tract, and of course they control posture, muscle tone, and our unconscious balance. Then we have going up in the purple, from the medial vestibular nucleus, crosses the midline to cranial nerve 6 to the lateral rectus, then traverses back across the midline to cranial nerve 3 and 4, the medial and superior oblique muscles. And then in the purple we have the up-up, or the vestibular nuclei output to the thalamus. So it goes from the superior vestibular nucleus to the thalamus via the ventroposteromedial nucleus, then the corona radiata, and then the lateral postcentral gyrus, the insular cortex, and the temporoparietal cortex, that we then become consciously aware of vestibular sensations.
Once we've determined that there's a problem or a malfunctioning in the medial or the lateral vestibular nuclei, there's specific treatment things that we can do. The first thing is that we can treat the vestibular nuclei and the vestibulospinal tract with cold laser therapy and with some acupuncture. So you see in the diagram, I've got circled in magenta where the labyrinthian complex is. And so the first thing is, if you have a laser that's a line laser at 635 nanometers wavelength frequency, you can shine the laser right on the vestibular nuclei going through the external auditory meatus. And then my particular laser has 2 apertures, so I'm going to shine the secondary aperture at approximately due 15 that's going to treat the brainstem simultaneously. And I'm going to do that for approximately 1 to 5 minutes. I'm going to do this while the patient is repeating the inhibition and facilitation patterns that were abnormal. So the simplest one, having the patient looking straight ahead, rotating head right and left, caused an abnormal facilitation inhibition pattern in head and neck or leg muscles or both, then I'm going to shine the laser in these 2 areas and have the patient repeat that head motion simultaneously for 1 minute, then retest, for 1 minute, then retest, for 1 minute, then retest. Then what will happen is you will get a failure that you've done too many. So then just need to make a note in your clinical records, okay, 3 rotations right to left in a minute worked fine. 3 minutes of treatment worked fine, 4 minutes created problems and recreated the initial problem. Something else you can do, this is a acupuncture point called VOL, small intestine 18. You can shine a laser on this. A lot of times we will put an acupuncture needle in that acupuncture point, depending on which side or both sides, while we're doing the laser treatment, while they're doing the head movement, all of this being done simultaneously. There's specific cranial therapy that can be done. So the sphenobasilar fault that you're all familiar with from your basic program. So a cranial inspiration, expiration assist would be appropriate to look for. And also a sphenobasilar inspiration assist and expiration assist fault would be totally appropriate also. Those of you that are familiar with osteopathic cranial manipulation, there's a specific cranial manipulation for the vestibular branch of cranial nerve 8. And so what I've done is created a AK protocol for this. So simply step number 1, you're going to therapy localize the greater ring of the sphenoid on the opposite side of the abnormal vestibular nuclei function. So if there's a problem with the left vestibular nuclei, you're going to therapy localize the right greater ring of the sphenoid, test your indicator muscle. Then you're going to find the vector challenge just like you would in a normal cranial inspiration assist to see what angle your correction is going to be. And then you're going to do a 2-point therapy localization with the tragus on the ipsilateral side and test your indicator muscle. Then you're going to find a vector for the tragus that you're going to pull the tragus, the ear, simultaneously, and then you're going to find the phase of respiration. So you're going to put those 3 things together. So you're going to contact the greater ring of the sphenoid on the opposite side, the mastoid on the ipsilateral side. You're going to squeeze those 2 together. If your hand is not big enough, the patient has a large head, then you're not going to be able to do this with one procedure. You're going to have to use 2 hands to do that, okay, with your inspiration component. And then the 3rd step would be to simultaneously traction the ipsilateral tragus. So let's backtrack. You have a problem with the left vestibular medial or lateral nuclei. You're going to therapy localize challenge the right greater ring of the sphenoid. You're going to therapy localize challenge the tragus on the left. So then you're going to treat right greater ring of the sphenoid, left mastoid process, and tragus of the ear all simultaneously. So it gets a little complicated. It takes a little bit of time to get the feel of using your hands simultaneously doing different things, but it's like any neuromuscular skill, you can learn to do it very quickly. Something else you need to consider therapeutically for the vestibular nuclei is in classic applied kinesiology, the upper trapezius muscle is related to the eye and the ear. So look for any upper trapezius involvement, and this could be the classic 5 factors of the IVF, or as Dr. Bandy has now gone into the aspect of trauma, the upper trapezius can be involved as a trauma mark with emotional trauma. In traditional Chinese medicine, you need to consider the kidney meridian because the kidney meridian controls the eyes and the ears, especially the ears. And then also in traditional Qigong medicine, the upper dantian, or the upper 1/3 of the body. The upper dantian is classic in terms of controlling head position, eye, ear function. So those 3 areas are additional vestibular nuclei therapeutic considerations that you need to think about.
Let's recap the entire protocol. To evaluate the vestibular nuclei in the vestibulospinal tract, first thing we have to do is we have to check head and neck flexor extensors, make sure autogenic inhibition is working properly. Check, that's for the medial vestibular nuclei. For the lateral vestibular nuclei, you're going to check trunk flexors extensors. We can use the quadriceps or rectus femoris, and then the hamstrings. Make sure autogenic inhibition is moving properly. Then we're going to complete the 3 different maneuvers with eyes open, then with eyes closed. So we're going to rotate eyes with head right to left, then retest flexors extensors, see if there's normal extensor facilitation and flexor inhibition. Then we're going to repeat rotation with eyes facing forward and fixed on an object, then retest head and neck flexors extensors. There normally should be extensor facilitation, flexor inhibition. And then we're going to repeat for a lateral flexion, eyes move the head, lateral flexion, eyes stay focused straight ahead, and then flexion extension, eyes move with the head, eyes stay focused straight ahead. If there's any disruption in the normal facilitation and inhibition patterns in any or all 3 of the 3 test challenges, then there are 3 specific things we can do to treat. First of all, we're going to treat with a functional neurological approach. We're going to do head motion and eye position using laser therapy on the labyrinth in the vestibular system through the external auditory meatus and at the brainstem at due 15. And then we can also do the electroacupuncture according to Vol at small intestine 18. We can needle that or we can laser that. What we typically do in our offices, we will needle that acupuncture point, then do the head and eye positioning systems with the laser therapy. Then we can also do cranial therapy. There are 3 specific cranial therapies we can do. We can do the regular cranial inspiration assist, expiration assist. Then there's sphenobasilar inspiration, expiration assist. Then there is a traditional osteopathic cranial nerve 8 manipulation that involves we contact the greater wing of the sphenoid on the opposite side of the lesion and the mastoid process on the ipsilateral side. We're going to need a challenge for what vectors we're going to use on those for correction, and then we're simultaneously going to traction the tragus on the ipsilateral lesion side, coordinating all 3 of those movements as the patient breathes in or breathes out, depending on what phase of respiration you found the problem in. Well, as Yoda said, much to learn you still have, as we all do. And one of the things that has driven me with this vestibular function is, of course, patients that have not responded to the care and the consciousness that I've had on dealing with concussions. Like Alice in Wonderland, I've gone down the rabbit hole of vestibular function. And one of the things that we're going to just touch upon, if we have a little bit of time here, is the relationship of the vestibular system and the limbic system. On the next series of slides and animations, you'll see the vestibular system and the limbic system. And this is kind of the rabbit hole I went down with these difficult vestibular injury patients and concussions. And here we have the semicircular canals vestibular nerve that we've been talking about, and then its relationship to the brainstem, but also to the hypothalamus and pituitary, and of course the amygdala. And then here we have the relationship of the vagus nerve, and then it is affecting the paraventricular nucleus and the pituitary gland, and ultimately the adrenal cortex with the production of cortisol. And then we get the gut referring back information to the vagus nerve, which then can override this entire situation. And finally, we have the neurotransmitters overlaying out of all of this. So you can see that the vestibular system is very complex. Here's another layer that we could add. We could probably spend the whole hour on just this one diagram alone of the transformation of sensory input into motor output and now chemical output as well in response to vestibular system injury in a concussion. The slides and handouts you received as part of your registration package are not in a print quality capability, and they would be printed over several pages. So if you would like some of the workshops that we're talking about, some of the forms that we're going to talk about a little later on, if you just take out your cell phone and send a text message to 844-539-1326 and type in the message, the word ICAK21, it will have a short pause or delay rather. It'll ask you for your first name, last name, and your email, and then it will send you an automated response, and then in about 10 minutes you'll start getting the forms for the questionnaires. You'll start getting the pages to print out so that you can have amalgamated stuff printed on 1 or 2 pages instead of 10 or 15 slides. So again, text the word ICAK21 to 844-539-1326. Let's recap the entire protocol. To evaluate the vestibular nuclei in the vestibulospinal tract, first thing we have to do is we have to check head and neck flexor extensors, make sure autogenic inhibition is working properly. Check, that's for the medial vestibular nuclei. For the lateral vestibular nuclei, you're going to check trunk flexors extensors. We can use the quadriceps or rectus femoris, and then the hamstrings. Make sure autogenic inhibition is moving properly. Then we're going to complete the 3 different maneuvers with eyes open, then with eyes closed. So we're going to rotate eyes with head right to left, then retest flexors and extensors, see if there's normal extensor facilitation and flexor inhibition. Then we're going to repeat rotation with eyes facing forward and fixed on an object. Then retest head and neck flexors extensors. There normally should be extensor facilitation, flexor inhibition. And then we're going to repeat for a lateral flexion. Eyes move the head, lateral flexion, eyes stay focused straight ahead. And then flexion extension, eyes move with the head, eyes stay focused straight ahead. If there's any disruption in the normal facilitation and inhibition patterns in any or all three of the three test challenges, then there are three specific things we can do to treat. First of all, we're going to treat with a functional neurological approach. We're going to do head motion and eye position using laser therapy on the labyrinth in the vestibular system through the external auditory meatus and at the brainstem at DO15. And then we can also do the electroacupuncture according to Vol at small intestine 18. We can needle that or we can laser that. What we typically do in our offices, we will needle that acupuncture point, then do the head and eye positioning systems with the laser therapy. Then we can also do cranial therapy. There are three specific cranial therapies we can do. We can do the regular cranial inspiration assist, expiration assist. Then there's sphenobasilar inspiration, expiration assist. Then there is a traditional osteopathic cranial nerve 8 manipulation that involves we contact the greater wing of the sphenoid on the opposite side of the lesion, and the mastoid process on the ipsilateral side. We're going to need a challenge for what vectors we're going to use on those for correction. And then we're simultaneously going to traction the tragus on the ipsilateral lesion side, coordinating all three of those movements as the patient breathes in or breathes out, depending on what phase of respiration you found the problem in.
Well, I'd like to thank you for being here. If you want any of the follow-up materials, we'll send you how to get a hold of us at the end of this presentation. The vestibular nuclei questionnaires will post a video so that you can rewatch this video of how to examine the patient and then how to treat the patient. And again, I thank you for being here.